Good afternoon. I'm going to talk to you about what we know about the effectiveness of policies and interventions to reduce childhood obesity and how we can best assess and model their impact. What I found from research over the past 3 decades is that if we want to reduce population obesity levels, I think we need to move beyond simply asking what is effective and start to seriously consider the cost of interventions and their likely impact on population health. Our Choices project over the past 8 years has examined more than 40 obesity policies and programs high on the national agenda. We've conducted systematic evidence reviews of more than 130,000 peer-reviewed publications to look at evidence of effect. We've estimated the cost of these interventions following standard guidelines and developed a microsimulation model using what we might call big data to project the population impact of these different interventions and their cost effectiveness over the next decade in the United States. Our model is kind of like a SimCity model. It's stochastic, discrete time individual level microsimulation model of the US population with 1 million simulated individuals. We use US Census data down to the tract level to draw our representative samples. We used all the behavioral risk factor and NHANES data to take into account growth in weight and height and BMI across the population, across the different states, take into account population growth projections. We use real longitudinal data from all the national longitudinal studies of growth over the life course, as well as national data on diet, physical activity, smoking, as well as our national life tables. We project what will happen over the next decade in the absence of intervention in terms of cases of obesity, health outcomes, and healthcare cost. And then we take into account the interventions and their specific effects, the evidence for effect, cost, and implementation, and project these outcomes over the next decade. We then contrast these results with what would have happened if we didn't implement the interventions to begin with. And all these projections we calculate are 95% uncertainty intervals using 1,000 iterations of the model for a population of 1 million individuals scaled to the population size. And we have a big cluster at Harvard, so we can run these. Here are some results for 3 much talked about interventions. This is our model. Sorry, I forgot to show you the picture. A sugar-sweetened beverage excise tax of 1 cent per ounce. This is not a sales tax, so the tax is directly reflected in the price displayed. It's also relatively inexpensive to implement. States already have excise taxes on cars and cigarettes. And there's strong evidence for the effect of this tax on consumption and of changes in consumption of sugary beverages on changes in obesity. This intervention, if implemented nationally, could be expected to prevent 576,000 cases of childhood obesity, and note the 95% uncertainty intervals here, to save an estimated $14.2 billion over 10 years. Now this we project to occur because of the slower rise in obesity with the sugar-sweetened beverage excise tax, and because healthcare costs are higher in children and adults with obesity. Note also that these calculations do not include any of the tax revenue. This would produce an additional $12.5 billion per year that could be used for other purposes, including supporting other obesity prevention initiatives. The second intervention we've studied is smart snacks, which is the second line there, part of the Healthy Hunger-Free Kids Act that has reformed school meals. Michelle Obama has been a big supporter. Basically, this intervention gets rid of junk food and sugary beverages in schools outside of school lunch. This is also an inexpensive intervention. We project it can prevent 345,000 cases of childhood obesity and save an estimated $792 million over this decade. Finally, another intervention we've studied is the expansion of bariatric surgery for adolescents with severe obesity. This is a very effective intervention. You've heard about that already. Our evidence review indicates a reduction in BMI of about 15 BMI units, but afterwards, severe obesity is still the norm because the adolescents begin with a BMI of 50. And few receive the procedure. Right now, of all adolescents with class 3 obesity, only about 2 per 1,000 get the procedure. So it is one of the more expensive interventions, but it's an important one, I think, as you've heard, and I want to emphasize that, but in terms of altering the course of the obesity epidemic, it really doesn't make much difference. It's too little, too late, too expensive. On this next chart, we show a cost-effectiveness metric. The sugar-sweetened beverage excise tax would save an estimated $33 in future health care costs. For every dollar spent on the intervention, it would save more than it costs to implement. The same is true of the Smart Snacks intervention. It would save $5 for every dollar spent on implementation. In contrast, increased use of bariatric surgery would not prevent any cases, so we can't calculate savings. But again, I think it's an important intervention. So these first two interventions seems like excellent foci for preventive interventions. And I should also mention that these results only look at child health outcomes. The sugar-sweetened beverage excise tax would also have a significant impact on improving adult health, preventing an estimated 1,900,000 cases of adult obesity, gaining an estimated 672,000 quality-adjusted life years, and preventing an estimated 43,000 deaths. So in summary, our work, I think, provides some clear evidence that some of the interventions studied are projected to save more in healthcare costs than they cost to implement. A sugar-sweetened beverage excise tax and Smart Snacks, part of the Healthy Hunger-Free Kids Act, are two examples of these. One simple policy implication is to make sure that the Healthy Hunger-Free Kids Act is continued. And states and cities can look carefully at the potential for a sugar-sweetened beverage excise tax to cost-effectively improve their population health. Now, I should note that only some interventions will be cost savings, like these. We need to invest in children's early education, and you don't get returns for many years with that. But we can always identify best value for money in each of these settings. Our work also clearly indicates that no one single preventive strategy will solve the obesity epidemic. We need multiple strategies in multiple settings. And as Bill Dietz mentioned before, it's clear that we cannot expect to treat our way out of the obesity epidemic. Treatment is important, but it makes a relatively small impact on obesity prevalence, too little and too late, and it is pretty expensive. So preventive strategies to slow the rise in excess weight gain over the life course are key. And let's gather data on effectiveness and cost of our strategies and start talking about their cost effectiveness and not ignoring cost. Policymakers, by the way, love talking about cost effectiveness. Thank you.
Okay.